Lipoprotein lipase deficiency is an metabolic disease. Look at this picture, shows that disease mechanism and causes of lipoprotein lipase deficiency. Detail going on. Introduction. Lipoprotein lipase deficiency is a rare genetic disorder that affects fat metabolism, leading to an accumulation of chylomicrons in the blood. This results in severe hypertriglyceridemia and an increased risk of pancreatitis. The condition is inherited in an autosomal recessive manner and typically presents in childhood with symptoms such as abdominal pain, eruptive xanthomas, and hepatosplenomegaly. A definition: lipoprotein lipase deficiency is a metabolic disorder caused by mutation in the LPL gene, leading to deficiency or dysfunction or the enzyme lipoprotein lipase. This enzyme is essential for breaking down triglycerides in chylomicrons and very low density lipoproteins VLDL. The absence of inefficiency of LPL leads to severe hypertriglyceridemia. More than 1000 mgdl, increasing the risk of acute pancreatitis and other complications. Etymology. The term lipoprotein lipase deficiency originates from the Greek word lipo, fat, protein, and lipase, enzyme that breaks down fats, referring to the enzyme responsible for fat metabolism. The deficiency aspect denotes the lack or dysfunction of this enzyme, leading to impaired lipid breakdown and accumulation. Types. LPLD can be categorized into 1. Classic LPLD, presents in infancy or at early childhood with severe hypertriglyceridemia. 2. Parietal LPLD. A milder form where some enzyme activity is retained, leading to moderate triglyceride elevation. 3. Acquired LPLD can occur due to conditions like diabetes, liver disease, or the use of certain medications that interfere with LPL function. Causes. LPLD is primarily caused by mutations in the LPL gene, which encodes the lipoprotein lipase enzyme. Other causes include 1. Genetic inheritance, autosomal recessive pattern. 2. Mutations affecting LPL function, affecting enzyme synthesis, activation, or stability. 3. Defects in apolipoprotein CHA cofactor required for LPL activity. 4. Secondary causes. Medications like corticosteroids, estrogen therapy, or uncontrolled diabetes. Risk factors. 1. Genetic predisposition, family history of LPLD. 2. Consanguineous marriages. 3. Presence of metabolic disorders, example diabetes, obesity. 4. Use of certain medications, estrogen, glucocorticoid. Complications, acute pancreatitis, life-threatening inflammation of the pancreas. 2. Eruptive xanthomas, yellowish pupils on the skin. 3. Hepatosplenomegaly, enlargement of the liver and spleen. 4. Fatty liver disease, accumulation of fat in the liver. 5. Cardiovascular disease, increased risk due to prolonged hyperlipidemia. Pathophysiology. Lipoprotein lipase is an enzyme that hydrolyzes triglycerides in chylomicrons and VLDL in LPLD. Mutations lead to loss of LPL activity causing chylomicrons to accumulate in the bloodstream. This results in severe hypertriglyceridemia, chylomicrons obstruct capillaries, leading to recurrent episodes, pancreatitis, excess triglycerides are stored in the liver and skin, causing hepatosplenomegaly and exanthomas. Pathophysiology of lipoprotein lipase deficiency, step by step process. 1. Genetic mutation. A mutation occurred in the LPL gene leading to absent or dysfunctional lipoprotein lipase enzyme. 2. Deficient LPL activity. Lipoprotein lipase is essential for breaking down triglycerides in chylomicrons, and very low density lipoproteins. Without functional LPL, triglycerides remain intact in the bloodstream. 3. Accumulation of chylomicrons. Chylomicrons, lipoprotein particles carrying dietary fats, cannot be cleared properly. This leads to severe hypertriglyceridemia, TGS, more than 1000 mg per dl. 4. Obstruction of capillaries. Large chylomicrons accumulates in capillaries, especially in the pancreas, liver and skin. This blocks, disrupts normal blood flow and tissue function. 5. Acute pancreatitis development. Excess chylomicrons trigger inflammation in the pancreas, causing acute pancreatitis, severe abdominal pain, nausea, vomiting. This is the most dangerous complication of LPLD. 6. Deposition in organs and tissues. Liver and spleen leads to hepatomegaly, enlarged liver and spleen. Skin causes erupted exanthomas, yellowish pupils due to fat deposits. Retina results in lipemia retinalis, milky white appearance of the retinal vessels. 7. Persistent hypertriglyceridemia. If untreated, continuous triglycerides accumulation increases the risk of cardiovascular disease, chronic pancreatitis, and metabolic disorders. This step by step breakdown explains how LPLD progresses and leads to its characteristic symptoms and complications. Signs and symptoms. 1. Severe abdominal pain due to pancreatitis. 2. Eruptive exanthomas, yellowish pumps on skin. 3. Lipemia retinalis, milky appearance of retinal blood vessels. 4. Hepatosplenomegaly. 5. Fatigue and irritability. Diagnosis. 1. Lipid profile. Elevated triglycerides more than 1000 mg per dl. 2. Genetic testing confirms mutations in the LPL gene. 3. Lipoprotein electrophoresis shows increased chylomicrons. 4. Apolipoprotein C 2 assay to rule out cofactor deficiency. 5. Fundoscopy examination detects lipemia retinalis. Nursing diagnosis. 1. Risk for imbalanced nutrition related to dietary fat restrictions. 2. Risk for acute pain related to pancreatitis episodes. 3. Impaired skin integrity related to eruptive exanthomas. 4. Anxiety related to chronic disease and dietary limitations. 5. Knowledge deficit regarding disease management and dietary restrictions. Medical management. 1. Dietary modifications. Extremely low fat diet less than 20 g per day. 2. Fibrosis, lower triglycerides, not effective in severe cases. 3. Omega 3 fatty acids, reduce triglyceride levels. 4. Lipoprotein apheresis, removes triglycerides from the blood. 5. Genetic therapy, experimental treatment restoring LPL function. Nursing management. 1. Educate the patient about low fat dietary practices. 2. Monitor for signs of pancreatitis, severe abdominal pain, nausea, vomiting. 3. Assist with medication administration. Example, fibrosis, omega 3 supplements. 5. Support psychosocial well-being through counseling. 5. Educate about genetic counseling or family planning. Treatment options. 1. Dietary therapy, mainstay of treatment, avoiding long chain triglycerides. 2. triglyceride lowering medications, omega 3 fatty acids. 3. Plasma exchange or lipoprotein. Apheresis in severe cases. 4. Gene therapy. Alipogench, Tiprovac, currently experimental. 5. Pancreatitis management. Intravenous fluids, pain management, and hospitalization if necessary. Psychosocial medicine, on counseling and support groups, helps patients cope with lifelong dietary restrictions. 2. Family education, educates caregivers on dietary needs and complications. 3. Behavioral therapy, support adherence to dietary changes. 3. Nutritional counseling, guides patients on maintaining balanced low fat diet. 4. Genetic counseling helps families understand inheritance patterns and reproductive choices. Prevention, one, genetic screening in high risk families. 2. Avoidance of high fat diets to prevent triglyceride accumulation. 3. Regular lipid monitoring to detect and manage hypertriglyceride early. 4. Prenatal genetic testing for couples with a family history. 5. Avoidance of triglyceride raising medications, example corticosteroids, estrogen. In conclusion, lipoprotein lipase deficiency is a rare but severe metabolic disorder that requires lifelong management. Although there is no cure, adherence to a strict low fat diet, lipid lowering medications, and emerging gene therapies provide hope for better disease control. Early diagnosis, genetic counseling, and lifestyle interventions can prevent complications, improving the quality of life for affected individuals. Ongoing research may bring new treatment options, making LPLD more manageable in the future. Thank you. Have a nice day.